Thank you very much. Good morning. Congratulations for this excellent meeting until now, and congratulations for your society. Very active society, very impressive society. I am going as chairman of the European section of Function and Female Urology. I'm going to talk about EU guidelines. The Guidelines Board decided that the incontinence guidelines were updated only every 2 years, which means that what I'm going to show to you is something that was updated after a search that finished by the middle of 2017, and in order to produce the guidelines that were presented in 2018, and they were not updated for 2019. So 2019 are a copy of 2018. And a new panel is now being prepared, because the previous panel, in which I was also a member, was there for more than 10 years, and there is a necessity of renewal. So you will see that some of my slides will be my personal opinions as a previous member of the panel, the directions that the guidelines will need to follow, taking in consideration the things that came out during the last 2 years. So, of course, we are going to talk about assessment and medical treatment, and I don't need to say that we need a good medical history, a full, complete physical examination, including prostate and vagina, in order to investigate patients with urinary incontinence. And this was already discussed last day, the importance of avoiding diary with at least 3 days of recording. About questionnaires, we don't have any evidence that by using questionnaires we are going to improve the outcome of the treatment, although questionnaires are sensitive to changes. And so the recommendation that appears in the guidelines is that they should be used if a standardized assessment is required, but not for everyday practice. We put a long list of questionnaires in the guidelines that you can visit, and you can decide which one is better if you need the standardized investigation. As part of the investigation, urinalysis is really required, particularly if there is a symptomatic urinary tract infection. Then the infection must be treated, and after the cure of the infection, the reassessment of the patient is recommended, strongly recommended. But if asymptomatic bacteriuria is present, particularly in elderly patients, there is no need to treat the asymptomatic bacteriuria in order to improve urinary incontinence. You might need to treat for other reasons, but not for the cure of urinary incontinence. PVR, of course, is important to be measured, particularly if there are voiding symptoms or if the urinary incontinence is a complicated one. Of course, it should also be measured if treatments that have been introduced might change voiding function, like antimuscarinics or surgeries for stress urinary incontinence. Urodynamics is always a matter of debate, and I think that Enrico is going to talk about that. But for conservative treatment, or before conservative treatment, certainly is not recommended. We do not recommend urodynamic studies before the treatment of uncomplicated stress urinary incontinence, and we do not recommend the use of erythropressor profile or leak point pressure to grade the severity of incontinence, because it is not easy to standardize these parameters throughout the different centers. Well, the treatment. In terms of treatment, everything starts by lifestyle intervention, and of course it is important to ask patients to stop smoking, drink less fluids, drink less coffee. But I believe that in Western societies, I think the most important step is to ask patients or to encourage patients to reduce their weight if they are overweight or obese, and to maintain, of course, that reduction. And that evidence starts many years ago with the PRIDE study, and clearly for mixed and stress urinary incontinence, by reducing the weight, it is possible to cure patients, and even the number of patients that might have a reduction in this study of about 50% or 70% in the number of episodes of incontinence can be 50%. So half of the patients can be strongly improved by the reduction of the weight, and that has been confirmed by further studies. Another point that is really important is to review the medication that the incontinent patient is receiving for their comorbidities, and in particular the new medications that were introduced if there is a sudden worsening or appearance of urinary incontinence. And I would like to show to you a very recent study coming from Asia, showing the importance of comorbidities to OAB. The prevalence of OAB, according to this study coming from Asia, shows that increases in patients with diabetes, hypertension, cardiac diseases, hyperlipidemia, smoking, alcohol, excessive alcohol consumption, which means that if we improve all these comorbidities, we might also improve the symptoms of OAB. Pelvic floor muscle training is recommended for mixed and stress urinary incontinence, and it is recommended that it should be supervised and maintained for at least 3 months. It is important to note that it can be offered to elderly patients, to elderly women, and also to young women after delivery if there is incontinence. And this last point is really important. Offer pelvic floor muscle training to patients, to women that are incontinent after delivery. Of course, it can also be offered to patients that had radical prostatectomy and are incontinent. It will speed up the process of continence, and the program should be as intense as possible. Many patients will require pharmacotherapy, and pharmacotherapy, the recommendations are simple. Antimuscarinics and mirabegron should be offered to patients who failed conservative treatment, and they are exactly indicated at the same level with the same degree of recommendation, strong recommendation. However, we recognize that long-term antimuscarinic treatment should be used with caution in elderly patients that are at risk or already have cognitive dysfunction. And of course, this is important in Western societies where elderly population is increasing. It is important to review the effect of medical treatment, because the first reason to stop medical treatment is lack of efficacy. And so early review to see if there is efficacy, if we have to fine-tune the dose, and also to check adverse events is extremely important. Early review. Of course, in many countries, antimuscarinics are still the first option because they are generics, and if they are not effective, we should consider escalation or a change to other drugs, antimuscarinics or mirabegron, or to use combinations. Because of the potential adverse events resulting from the large distribution of antimuscarinic drugs, antimuscarinic receptors throughout the body, the antimuscarinic drugs are offered in low doses. And in fact, they are not extremely effective. If you look to the column on the right, you see that you might need to treat 8, 9, 10 patients in order to get one patient cured. And there are no big differences among the different antimuscarinic drugs. In addition, it is important to remember that these findings concerning antimuscarinic drugs put a problem about the long-term use of antimuscarinics in elderly patients, the risk of dementia and Alzheimer, the loss of memory, which increases with longer exposures, and in some patients exposed to anticholinergic drugs, there is also a risk of brain atrophy. That was demonstrated basically for drugs that were not exactly those that we use for the treatment of urgency urinary incontinence, but in this study that was not evaluated by the panel for the actual version of the guidelines, shows in Taiwan that at least patients with diabetes are at risk of developing dementia after oxybutynin, tolterodine, or solifenacin, oxybutynin being the worst, solifenacin being the best one or the safer one, but anyway, all of them have a significant risk in patients with diabetes. That might indicate that the risk of dementia might not be exactly the same across all patients, but might be more severe. The risk might be higher in particular groups. About mirabegron, we recognize from the evidence that is better than placebo and as efficacious as antimuscarinic drugs in terms of improvement of urgency urinary incontinence or OAB symptoms in general, and in terms of adverse events, they are very similar to those we see in the placebo arms. And the statement about the efficacy of mirabegron resulted or came out from this systematic review. The vertical line that you see is the efficacy of mirabegron 50 milligrams for the reduction of the number of micturations per day on the left and incontinence episodes on the right. And the horizontal lines are the effect of antimuscarinic drugs. And you see that the lines cross, the horizontal lines cross the vertical lines, which indicates that the efficacy of all these drugs is very, very similar. The confidence intervals are across the vertical line. About adverse events, and this is a very recent study that explored a large Astellas database involving more than 5,000 patients that received mirabegron and almost 3,000 patients exposed to antimuscarinic drugs. It will come out very soon in European Urology, is already accepted. Shows that below 75 and above 75, we might see years of age, we might see some differences. Below 75, clearly, dry mouth is the most important symptom that differentiates mirabegron from antimuscarinic drugs. Above the age of 75 is dry mouth and constipation. There is much more constipation among patients receiving antimuscarinic drugs than receiving mirabegron, which is exactly the same as in the placebo groups. About hypertension, below 75, there is no difference between the three groups, antimuscarinics, mirabegron, placebo. Above 75, we found 1% higher in terms of difference between mirabegron and antimuscarinic. So there is always the need of checking blood pressure in patients that are treated with mirabegron 50 milligrams. Nevertheless, with the efficacy and the low adverse events, we have seen throughout the world an increase in persistence and adherence of mirabegron when compared to other antimuscarinic drugs. This is coming from UK, and really we can increase the persistence on medication for more than 3 months in average. And persistence is an important issue in OAB treatment. In EU guidelines, you don't see anything about combination therapy because all this data appeared afterwards. But combination therapy is important for patients who do not respond to monotherapy, or in patients in which or in whom we don't want to escalate the antimuscarinic drugs due to adverse events. And the combination of mirabegron with solifenacin 5 is better than solifenacin 10 in terms of improving continence and reducing the number of episodes of voiding episodes per day. Also important, the combination increases the number of patients that are fully dry. And so combination therapy in patients who do not respond to monotherapy, I believe that will be a recommendation in the next guidelines. Also, combination can be put in the other way around. Many patients start now by mirabegron, and if they do not respond to mirabegron, the add-on of antimuscarinics in this MILI study demonstrates that it's possible to improve OAB symptoms in similar way. So the combination can be performed in the two ways, whether we start by antimuscarinic drugs or by mirabegron. We can combine the other component. Nothing new about duloxetine. There are new drugs being investigated, but they are not yet in the market, so they can be used in selective cases of stress urinary incontinence. Desmopressin is not recommended for chronic treatment of urinary incontinence, but might be used in occasional short-term situations because it reduces the production of urine in next 4 hours, and so it might protect a particular patient of incontinence during a couple of hours. Estrogens might improve symptoms in women that have vaginal atrophy. If they have breast cancer history, the oncologist should be consulted, of course. And I am not going to talk about botulinum toxin, but what I want to discuss as the final slides with you is the ABC trial. Looking to the ABC trial, clearly, the first idea is that 100 units of botulinum toxin, of onabotulinum toxin, and solifenacin in optimized form of administration are similar in reducing the number of episodes of incontinence. However, if you look to the number of patients that are really dry, it is exactly the double with botulinum toxin when compared to solifenacin, and this last meta-analysis, very recent meta-analysis, shows, in fact, that botulinum toxin is more effective than any oral drug if we really want to provide continence, full continence to our patients. So as final keynotes, careful medical and clinical examination and a 3-day bladder diary, correction of obesity, particularly in our Western societies because we are becoming obese. Optimizing the control of comorbidities may improve OAB. Antimuscarinics and mirabegron are equally effective, although in terms of safety of adverse events, the risk is different, and combination therapy will be used more commonly in future in patients who do not respond to monotherapy drugs. Thank you very much.